Hello, my name is Martin Lipscomb and I'm talking today with Clare Kirkpatrick. Clare is a deputy manager at a nursing home in Gloucester who's recently completed a master's degree in advancing practice, healthcare, leadership and management here at Worcester, and today she's kindly agreed to talk about her dissertation that was rather well done and which was submitted in part fulfilment of the master's course. Clare, please, can I ask you to introduce your work? What was it that you investigated? Why investigate this topic? How did you go about your task? And most importantly of all, what was it that you discovered?
Okay, thank you. So as a deputy manager, part of my job is clinical leadership in a nursing home. Coming into social care from the NHS was a bit of an eye-opener. When trying to work out what approaches we were going to take to quality improvement and to clinical management, I found it difficult to find evidence. So when I did my started my master's and when I was preparing to do my dissertation, I thought I need to do something about this evidence base, and particularly with regards to clinical safety. My degree was in healthcare leadership and management, so it needed to encompass that as well. So I decided to explore how managers in care homes approach clinical safety and how they feel about it as well. When I did my literature review, I found what I had suspected, which was that there really is a very, very poor evidence base. There's just hardly any research being undertaken in care homes at all. There's an organisation called Enrich that that is about trying to promote research in nursing homes. So it's recognised that that's an issue. But the research that I could find about clinical safety and about management was extremely sparse across the world, but particularly in the UK. There's a bit in Scandinavia where they're starting to look at safety culture in care homes, but only just starting to. And safety culture has been something we've been talking about in other industries since Chernobyl in the 80s, and in healthcare for at least the last couple of decades. So it's a bit disappointing that it's only just being picked up in social care when it's such an important area. So I knew that's where I needed to do my research. And then it was thinking about my methodology that I was going to take. When I did my first degree, I was terrified of the research module and I hated it. So I was really nervous about the research methods module for my master's, but I absolutely loved it. I got completely drawn in. And I was particularly drawn into the sort of the philosophical discussion of understanding about how we the nature of being human, the nature of knowledge and how we acquire it and what we do with it. And when I was thinking about understanding what care home managers actually feel about clinical safety, I realised that I needed to think much more in line of a qualitative phenomenological approach to the research. This obviously allows you to understand much more about their experience and placing that in the context of their life experience as well. So that was the approach I took, and I specifically took what's known as a Heideggerian approach, because he was a philosopher who felt that the researchers' proximity to the data actually should be embraced, rather than having that very objective view that science usually does, that the researchers should be completely separate. He thought that you should embrace that closeness to the data, because you can get richer data through that. And actually that is what I found. As a deputy manager, I already understand the sector and the work that's being done, and I knew the participants, so I already had a relationship with them, which meant that I didn't have to build that trust. It was already there and I could get closer to the data quicker. So I did qualitative interviews, semi-structured interviews. I did 3. The first 3 were done in the managers' care homes. We sat down and they were recorded on encrypted devices. And I had a few sort of prompt type questions, but really I wanted to understand what was important to the managers. So I was prepared for the interviews to go wherever they went. And as long as I just gently steered it back to clinical safety, if it veered too far off. So the first 3 were in their care homes, as I said, they were really interesting interviews. I didn't transcribe them until I'd done all the interviews. And then coronavirus hit, and I couldn't go into the care homes, and I didn't want to put any pressure on the managers, and I was under a lot of pressure as well. So everything went on hold for a couple of months. And once we'd kind of got the hang of what we were doing in the care homes, I gently approached the other two managers, and they said that they'd be happy to do a remote interview. In fact, they were very keen to. So I did the last two over video conferencing software. I did think that the whole crisis and everything would really affect the data in a negative way. On the contrary, it was incredibly useful to have the data from both sides of it. Actually, obviously, I wasn't doing a compare and contrast style study, but I had to work with what I had. So what I found out was, firstly, a little bit about what I expected to find, that they used systems that they developed through their experiences they'd had to date, either in nursing or in social care. They worked and understood, they talked about teamwork and about communication and all the sorts of things you would expect. The largest finding that came out of it, there's a group of findings, was really about how clinical safety of residents in care homes is hindered by stuff that is completely outside the manager's control. So they could be absolutely outstanding managers with a fantastic leadership style and a great team, but the stuff that's going on around the care home that they have no influence over, and that gets in the way of them achieving the best clinical safety. So that came under a few areas. The first one was the provider, the person who owns the care home or the group of care homes. Sometimes that's a very, very large organisation, with several hundred care homes, and sometimes it's a very small one. Sometimes it's just single ownership. But it seems to be affected by whether or not the organisation is profit making, or whether or not they're extremely large or very small, or what the experience of the provider is. But the managers kind of unilaterally said you can either have a provider that makes it easier to achieve clinical safety, they'll buy you the equipment you need and they'll get you on the training you need, or a provider who is mostly interested in getting people into beds. And, there's that sort of profit driven side of it. So that was really interesting to understand that impact. Then you've got how regulation works. So obviously care homes are inspected by CQC, and they're subject to ratings. What the managers talked about was they're also inspected by local authorities as well, separately to CQC. What the managers talked about was the time spent providing evidence for inspections. I did more research into this and found that there is a strong argument for not having a ratings-based regulation system. It should meets the regulations, doesn't meet the regulations. Because there is an element of chasing the ratings. There's a lot of argument for reform of the regulation system, and it seems on the floor there is a strong argument for that as well. And I think that needs to be researched in a lot more detail, really, because it's not really understood how. That's the other thing I found, that somebody's talked about. I did some research and found a few incidences where CQC had rated a care home good, and yet there'd been abuse ongoing at the time of the inspection. So it's not just that they impact the clinical safety just by the fact they're doing inspections, but actually they're missing stuff anyway. So is it fit for purpose, was the sort of thing that came out from that. As well as regulation, the other thing that came out was the relationship with external agencies, so social care and the NHS, and how that can cause problems for managers in ensuring their residents are clinically safe. So things like communication, handovers on discharge from hospital, paramedics not insisting on taking residents to hospital whose advanced care plan says that they don't want to go to hospital. That was a really interesting thing. Shortages in the NHS was an issue as well. So for residential homes who are relying on district nurses, if they are short-staffed, then they can't get into the home as quickly as they need to necessarily. So insulin injections, that obviously must be given at specific times. Sometimes people will have to wait for those. End-of-life medications they may need to wait for. There may not be any continuity of care with wound care management. Apart from the end-of-life care medications, there's no reason why carers can't There's no legal reason why carers can't be delegated those tasks by a registered nurse, and that the residential homes can't be commissioned to do those tasks. But the district nurses have that commissioning at the moment. But it means that people are waiting for care. When coronavirus hit and the district nurses and GPs said we're only going to come in if we have to, all those tasks were delegated to the carers, and they did a really good job of it. And the managers who I spoke to after the coronavirus hit said, we wish it will continue like this. Wounds are getting better quicker, people are getting their blood sugars more stable. That was an interesting point to come out of it, was that the commissioning needs rethinking as well. So the main thing that all of that brings together is possibly a massive need for massive reform, but also if there is going to be reform, there is no evidence base for it. And I know the government are talking about reform at the moment, but they're just, the only way to do it is to try things out, because very few people is doing research into how we make sure these most vulnerable people in our population are kept safe. And obviously that's been shown by the awful situation with coronavirus, the poor infection control understanding in some care homes, not all, but there's that lack of consistency that's really problematic that you don't get in the National Health Service. Do we need a national health and social care system rather than independent sector in the National Health Service? I don't know, but something needs to change if we want to make sure these people are safe. So that was the outcome of my research, really.
Your outcomes are very broad and they're really interesting. What will you be able to take forwards from this into your real world practice?
In terms of real world practice, I think it's been really helpful when communicating with people, the people that I'm responsible for in a managerial perspective, but also relatives of people planning to come into a care home. I mean, I'm not necessarily telling them, oh, your loved one won't be safe because they're going into a care home, but having such an in-depth understanding of the health and social care system and how those complexities impact on people living in care homes has been really important. In fact, there's been one really vital example was when I know of someone who needed CPAP, which is a aerosol generating procedure. It's something that's not often coming up in care homes. So unless care homes know that that's an AGP and you need specific PPE for it with fit tested FFP3 masks, I'm sounding like I'm from line of duty now with all these acronyms, they would accept that person and put their staff potentially at risk and the rest of the residents. But finding out the information is really, really difficult. So from my point of view, knowing that enabled me to give some advice that was about, you've just got to keep pushing. You've got to try and look everywhere because you have got to find out the information and it's not going to be easy to find. But they did get the information. They did get the support they needed, thanks to some colleagues from the health sector working together with them. But it is that lack of joined up working. Understanding it allows you to maybe mitigate some of the issues a little bit, I think.
Claire, I've seen your dissertation and it's a very impressive piece of work, and you've obviously taken a lot from this. And I'd just like to again say thank you very much for explaining what it was that you did. And I think that it's a good example of where the dissertation allows people to flourish and discover things that it's difficult to imagine how they would otherwise do those things. So thank you for talking to me today. I've enjoyed listening to what you had to say. Thank you.
Thank you.